Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Good morning, Nora. How are you doing?
Very well, Brian. How about yourself?
Doing good. Yeah, everything's going really good. I think we're both preparing for our China trips. You're going to many parts of Asia. I'm going to China for 3 weeks to be teaching. So yeah, it's all about, let's hope I don't forget this. Let's hope I don't forget that. Okay, what do I need? We were just talking about, getting your pelvis ready for this class, pelvic bones, that is, not your current pelvis, but getting that ready. And I'm thinking, okay, what bones do I need for this class? What bones do I need for that class? So yeah, it's one of those things, because once I leave, that's not something you can pick up at the local drugstore.
No, we start to put together the pile, right? So the pile's got things like all the currencies for the different countries we're going to, and we just sort of start the pile starts to build right in the packing area, and it just like builds and builds. Just as you remember something, put it in the pile, right? Like we have to remember umbrellas because it'll probably be raining in at least a couple of the spots. Just stupid stuff, but like just put it in the pile. Then it's all there when you go to pack.
That's a good point. I actually hadn't thought about that. Umbrellas is something that I don't think about, but that you're absolutely right. And the currency, I forgot the last time I was there, I had some currency I brought home. So it's like, yep, I got to remember to bring that with me. Yep. So thank you. Thank you for reminding me. It's sitting on my desk.
You're welcome.
Thank you.
Just what you need.
Well, today we have a very interesting topic.
We do. We're kind of excited about it. It's complicated. So morning.
Gosh. Yes, this is going to be one of those. We're going to do a deep dive. It's going to be a little complicated. We both have case studies that we were like, let's do a case study. Oh, how about this? Oh, yeah, I've got perfect example. So we're going to dive in just a second to the SI joint. But before we do that, do us a favor, hit the like and subscribe button, share, comment, do all the good stuff. It really helps us out big time, helps us to get more guests on, and really helps to promote our channel. We really appreciate it. Check us out at Moving Combos on Instagram, as well as movingcombos@gmail.com. It's the best way to get in touch with us. So now on to the sacroiliac joint.
So just as a brief introduction, any of you who have worked with clients with sacroiliac joint problems, or perhaps you have one yourself, this is what I often say about the sacroiliac joint. It doesn't have a lot of muscles that directly cross it and stabilize it. So in order to really stabilize the sacroiliac joint, you have to stabilize the entire torso, all the muscles around the pelvis, and all the muscles of the lower body, basically. So that's the overview. Just do that and you'll be fine.
All right. We'll see you next week. That's all you got to do. Yeah, this is one of those areas that when you think about it, it sounds fairly easy. How do we want to stabilize that area? You hit everything, right? But there's a lot going on. There's a whole lot going on. And I just saw my gentleman this morning, which is why it was on my mind when you said, let's think of a case study. Do you want to do a little bit of the anatomy first, and then we'll talk our case studies?
Sure. So the key thing about the sacroiliac joint is, it's where the ilium meets the sacrum and forms the ring of the pelvis, right? In the front, you've got the pubic bone. Around the back, you've got the pelvis, the sacrum. I've got a picture up on YouTube. Those of you who are on YouTube, there's a little pelvis. You can see the back of it. So the ilium here comes and joins into the sacroiliac joint. And one of the things I'm showing right now is just that there's a little bit of motion. There's a little bit of almost like a rocking motion that happens, and this would be a normal thing to happen with walking. So showing the front of that, right? It almost looks like a little butterfly joint, and it's a funny joint. I'm going to take apart something here.
So for those of you who are listening, think of it this way: the bottom of your lumbar spine has that V, and that's your sacrum, where that connects to your hip bones. So if you feel on your sides, you can feel the hip bones, and the highest point is sort of where she was talking about the butterfly wings. That would be sort of the highest point of a butterfly wing, where those bones connect to that V. That's your SI joint. That's your sacroiliac joint.
And so now I have the sacrum taken apart, which is kind of funky. But if you look at the edge of the sacrum, like this is a weird joint because it's basically like this looks like a landscape. It's got flat spots, it's got bumps, it's got ridges on the sacrum side, and it has matching bumps and ridges on the ilium side. So rather than being like, a ball in a socket or a hinge
Exactly.
joint or something like that, it's like a whole bunch of ridges and bumps meet another series of ridges and bumps to form the joint. It's also half a synovial joint and half not half a sort of cartilaginous joint. So it's got different qualities to it as well, the two different halves of it. So that is the sacroiliac joint roughly. Then there's a tiny bit of motion there. And again, I showed probably an exaggerated motion when I was rotating it a moment ago, but there is a small amount of motion. Oh, something just fell off here. Sorry. Pause. There's a small amount of motion in the sacroiliac joint. And that lost my AirPod. So that's funky because what that does is if that motion is equal on both sides, right? So every time you step, it moves just slightly one direction, slightly the other direction, and they move in opposition to each other in a walk and a reciprocal leg motion. If that happens, then you've got pretty good force transfer from the femurs up through the pelvis and into the spine. For a lot of people, that doesn't happen that way. One is either too loose, so force doesn't transfer as smoothly on that side, or one is too tight. So force transfers more immediately. And a lot of times that imbalance of mobility on the two sides is what causes pain and discomfort.
Yeah. And what we said before, there's no muscle that actually crosses this joint, much unlike a lot of other joints. If you think about the hip joint, for instance, there's a ton of muscles that are actually holding that ball into the socket from all these various angles. So that would be wonderful if the SI joint did that. However, the only thing that gives it stability really are ligaments that hold that together. But as we know, with ligaments, through anything like pregnancy or through spraining them, overstretching them, they don't always come back into the same way that they should. So that can lead to inherent instability. And if those ligaments are overstretched, one side, the other, both, that leads to that instability. So that's why we need to focus on all those muscles, really trying to keep everything in the area in place so it doesn't want to go out of alignment.
So, yeah, exactly. So that's why things are a little bit complicated in terms of trying to stabilize that joint. Because again, it doesn't have a lot of muscular support. So the best way to stabilize it is to have the femurs working in a balanced way, the low back working in a balanced way, and the force coming up through the pelvis into the sacroiliac joint, into the spine, being as even as possible. If there is a leg length difference, if there is a mobility difference, if there's a scoliosis, if there's even just a difference in the structure on the two sides, that will change how the forces move through that area and can create different amounts of mobility on each side.
Yeah. And also think of it this way, when the more muscles you have that attach into a surrounding area, when you have ones that become hypertonic or too tight, you have some that become too mobile or stretched out, what you're going to have is that muscular imbalance that can create that torque, that can create those shifts so that the pelvis can be sort of locked into one position because either one side of their low back is really seized up. So it's causing that hip to want to go upward or rotate forward so that top of the ilium is now being sort of lifted toward the ribs. Or if one side hip flexor is way too tight, it'll do the same thing, take it into that anterior tilt, trying to dip it forward. So muscular imbalances can also be some of the root cause of this as well. So it's really a challenge. And you said the perfect thing. It's creating a balance between the sides. You want a balanced approach.
And, as we all know, and any of you who work with clients, like very few people are actually very balanced, right? As I always say, if I meet somebody who's perfectly balanced, I'm going to bronze them because they're the only one. Right, we're all asymmetrical in various minor or major ways, and the SI joint is where some of that can show up.
I was talking to someone yesterday. I said, look, you look at a child, they're fairly well balanced because that's how most of them came from the factory. That's just the way that they're made. But as we get older, everything that we do and everything that we don't do leads to what we see today. So being, in my early 50s now, everything that I've done, everything that's happened to my body, every sport that I play, everything leads to what I see in the mirror and leads to those muscular imbalances that we're always trying to help eliminate. And that's what we see with our clients. If they sit at a desk all the time, we can usually see it. If they've played sports, we can usually see it because those imbalances show up.
Yeah, and last. Really
And
last and last and last. All right. So talking about sacroiliac joint dysfunction, SIJ dysfunction, a couple things occur. One is, where is the pain coming from? Like, I often think, just where is the pain coming from? And with the sacroiliac joint, when that gets unstable, or when it's unevenly stable, like stable on one side, not so stable on the other, that disrupts how all the muscles that attach to the pelvis, both above and below, are going to respond.
Mm-hmm.
So that means that, let's say there's a looseness on the right side, and that SI joint kind of slips around on the right side. That means, for example, the quadratus lumborum on that side is less solid in terms of where it's going to be moving from, because instead of having a pelvis that's relatively solid and it can just respond to that bone position, it's going to go, oh wait, maybe I need to spasm, maybe I need to tighten up to try to stabilize this. So typically I find, I think we called them the troublesome trio or whatever, the psoas, the piriformis, and the quadratus lumborum are often the three muscles that I'll call it try to stabilize the sacroiliac joint. They don't usually succeed, but they try. So I'll often find that one or the other, or all three in a circle, will go into spasm to try to stabilize that area when it's not reliable.
Yeah, I find it's the QL primarily is what I see in my practice the most. The QL, and usually when someone comes to you with this, they'll often have pain, low back, often to one side, and it's usually belt line, one side. If it's both sides, it's usually more low backish, but if it's on one side and sort of that, you could almost do a pinpoint, like right there. That's usually when I say, yeah, that sounds very much like an SI joint issue. And usually it's that QL that is just hunkering down to try and stabilize. It's like, I got this, and it just pulls and clamps down. And then I see the other three sort of respond, or the other two respond to that. The piriformis and the hip flexor say, oh, we'll help out. And then they get in on the act. So then when all of them get tight, oh, you can be in for a world of discomfort.
It's also, that it's a funny area where pain, the thing about the SI joint is usually pain is fairly localized. I mean, it can spread, and it can also influence things like sciatica and disc problems, other kinds of things. But to some extent, it's like when they point right there, right? They point not in the center of the low back, but off to that one side. They can usually kind of point like it hurts right here. So that's, that usually suggests the SI is part of it. Now, what I said that intentionally, SI is part of it, because typically when the SI joint is out of whack or causing pain, there's oftentimes a low back component. There's oftentimes a hip component. And so you can't just look locally, because oftentimes the trouble's either above or below that.
Yeah. Yeah. We definitely see that. We see that it's either low back, hip oriented, something. And I mean, we've talked about referred pain quite a bit on this podcast. And this is one of those areas. And it's sort of, think of it as a junction between your spine and your lower body. That's sort of a big junction point skeletally. It's a junction. And like you said, unlike the hip joint, which is a ball and socket that's held solidly and everything's wrapped up tight, and it's not going to necessarily go that far unless some major trauma happens to it. Here, we're talking about two relatively flat-ish surfaces, that do nestle together, but it's not that tight a connection. So it's hard. It's a hard place to transfer that force from the lower body through the core and into the upper body. And if it happens there and that's not in the right position, it's not placed right, or it's out of whack, that's where the pain is usually going to be felt.
Exactly. So I've got a client, and this is case study number one. Brian's got another client, case study number two. And it was interesting because SI joint issues for sure, but also knee pain, hamstring discomfort, lower leg discomfort, like that whole side was a little funky.
Mm-hmm.
And also pelvic floor dysfunction along with that. And so, just working with her was like, oh, this when this gets out of place, this fundamental stability structure in the body is no longer taking that role as a fundamental foundational stability structure. Everything responds to that, not positively, right? And so that also clued me into how much like the pelvic floor can also have an influence on that. That will move the sacrum in certain ways. It can stabilize the sacrum or not. It'll keep the femurs in place, and it connects, like the piriformis connects the sacrum to the femurs, for example.
Mm-hmm.
Yeah. So looking at all of those pieces, and including the pelvic floor in that, were all really critical to try to find how to stabilize this joint.
And you said something that I think is not said enough, is the influence of the pelvic floor on that joint as well. Because I often say that that's sort of your internal, whereas a lot of these other muscles are much more external. It's like everything else from the outside is holding it in place. Well, the pelvic floor to that sacrum, as well as the pelvis, that's internal. That's really the rebar and concrete that's trying to hold it together from the inside. Exactly. And keeping it snug together. So the pelvic floor has a huge and critical part to the SI joint.
And I don't know about you, but a lot of my clients with sacroiliac joint issues, they came on during or after pregnancy.
Yes.
Right. So there is some period of time when everything was loosened up from relaxin and birth and all that stuff. And the SI joint never quite returned to its previous happy place.
Now, question for you. I find that for people who just had one child, there's less likelihood than multiple children. My wife was one, and that sort of clued me in on it because I'd asked clients before, and it really clued me in. My wife didn't have any issues after our firstborn. Our secondborn, she started developing SI dysfunction, just mild, but we were able to get it under control for the most part. And I started every client that's come to me that said, I said, second, third shot. She goes, how'd you guess? I said, okay. So it's one of those things that it's like, oh, so it stretched out the first time, came back together. It's like, okay, we can do this. The second time it goes stretched out, it comes back. It's like, I don't know.
And the other little piece on that too, which this gets a little bit into our pregnancy stuff, that is episiotomies. So if there's a tear through the pelvic floor during birth, which is not uncommon, either repaired or not repaired, whatever the situation is, I find that was also another clue to me that the pelvic floor is a critical piece of SI joint dysfunction, because so many women, again, it wasn't just that they were pregnant and had birth or one or two or three, but it's also that they had episiotomy tears every time. So that then that pelvic floor is scarred up and isn't really responding as it was before the deliveries.
Interesting. I had never thought of that, but that's something to ask. Good point.
Yeah. So Brian, talk us through your case study.
Oh, this gentleman. Okay. He's in his late 70s. He's had this issue for about 15 years, at least. He's one of these that when I did my, go ahead.
I pause just a moment. So number one, he's a man. That's unusual. So I just want to point out a couple of things. Number two, he's older. That's also unusual. The sacroiliac joint often auto-fuses sometime in our 50s. Like just all those little, because, again, it's kind of like that landscape. They just start to fuse, and often you get more stable as you get older. Anyway, carry on.
Yeah. No, and that's something to keep in mind. I've had a couple of men have this happen later in life, and it's usually, and this is part of the issue, his happened 15, 20 years ago. He had a serious fall. That he thinks led to it, and that happened in his 20s or 30s, and didn't bother him at the time that much. But over time, it started bothering him more and more and more. He started doing physical therapy, got it under control, no problem. Well, then he had other issues. He needed a hip replacement. He had meniscal tear. He also developed severe low back problem, which ended up in an L5-S1 fusion. Now,
Oh, there we go.
that was the big one.
Yeah, that was the big one.
And he said, after that, my SI joint cannot get back together. He said, it's been nothing but problems. And this was in 2021, 2022, I think, that he had the fusion. And he said, it's been increasingly troublesome ever since. And it makes total sense from our point of view, because anytime you have a fusion, well, the above and below joints, well, they become more unstable and more vulnerable. That's the word I really want to use. They become more vulnerable. We often see if it happens at L3, L2, and L4 discs have a tendency to delaminate and herniate or have issues possibly down the road. Well, guess what? What's below S1? The SI joints. Yeah.
This is just, again, I want to just bring that piece up, which is anytime you have, it doesn't have to be a fusion. Anytime you've got real limitations in mobility in a certain area, it will put stress on the areas above and below it, whether it's the scapula doesn't move, or the cervical spine doesn't move, or the thoracic is really stiff, or whatever. The knee, exactly. Anything that doesn't have, again, I do think of it as force transfer. Like it passes the load evenly, or the load gets stuck.
Yep.
And in this case, the SI joint, when that low back was fused, the SI joint had to take all of the force and wasn't stable enough to do that.
Yep. And that's really what it seems to be happening, because it really was then that all of this ignited the most, and it's gotten worse over time. And in talking with this physical therapist he's been working with off and on for the whole 15 years, he said, this guy's in great shape besides this. Yes, he's got orthopedic problems, but he works hard. He's willing to do the exercises. He's willing to work hard. But this has been a spot that just will not go away. And they've brought up fusion to him of fusing the SI joint. Now, what's interesting, and I'm going to bring this up here, only because we've been talking about the above and below joint. I had a woman who had a good portion of her spine fused. She had all the way from L1 disc or T12 all the way down to L4 disc. But L5 and S1 were not touched. And at the time, part of me was thinking, I wonder why they did that. Why did they leave that one? Because it had some degenerative joint disease. It had some issues. The doctor could see that. But I do wonder if, because of her mobility issues, she's older, she's much older, did they think, let's leave that alone so that it doesn't affect the SI joint? I don't know. It was just one of those interesting things. And she asks all the time, she goes, why didn't they just do it? Now that hurts all the time. And it's affecting, this. I don't know. I don't know the reason, but I do wonder if that might have been a thought process. I don't know.
Interesting.
I don't know. Yeah. So just one of those things that made me think. And again, if anybody out there has had a similar thing or knows about this, let me know, because this is something that I've always wondered with this other client. But with this gentleman, we're going to call him R. Today was my first session with him. I did the assessment, and the assessment went great. He has good range of motion. Everything seems to be working properly. He's got good strength. He doesn't seem to be lacking in any nerve. Everything works fine. Today, man, anything unilateral whatsoever, even marching, the only thing he can do that's unilateral that doesn't cause him pain is walk. That's it. Everything else, marching, flared him up. Just lying on his back, marching. And I talked to the physical therapist, and I knew unilateral work was going to be out of the question. But usually something simple like marching or whatnot is something that they can usually do. And I just wanted to get a little bit of core stability work, and that was a no-go immediately. So I said, okay, when they say bilateral on this gentleman, they mean bilateral.
Bilateral. And
it was everything had to be. It was very interesting. It was very interesting working with him on what was working and what wouldn't work.
Uh-huh.
So that was
And
where my mindset had to change.
which side was is the pain on? Which
Left.
side is the
It's
left?
his left
Okay.
SI joint that's hypermobile. And the other side, I mean, you can definitely see it when he's on his back. You can look at his pelvis and you can see that there's an obliquity. There's something that's not quite right. And it's not my job to put it back. So I'm not touching it. I can work with muscles, but I'm not doing any mobilizations or anything like that. That's for the physical therapist to do. But I could see it. And he asked me, he said, "Can you see it?" I said, "Oh, big time. Big time." His left pelvis was rotated forward quite a bit toward me, because that leg was a lot longer. When I had his legs side by side,
Mm.
it looked probably an inch longer, maybe a little bit more, because I held his malleoluses up together and I was like, oh my gosh, they're really a huge difference there. And again, okay, we worked on stretching. We worked on trying to get a few things just gentle, stretching and whatnot. But that was an issue. So it just taught me that, okay, when they say bilateral, we mean only bilateral. For a long time, I have a feeling that he's going to be like that.
So one of the things, a couple of things I've played with here. One, clearly this guy's hypermobility, so that's what's happening there.
Yeah,
Pain can come from mobility, can also come from arthritis and kind of actually I would say not mobility, but like less range of motion and stuff in the SI
sure.
joint. And I think it's pretty simple. A very simple way that I use to test that, we may have talked about this before, but I'll talk about it again here, is I find like if I'm just trying to figure out whether that, I call it the SI joint wants to be closed or wants to be opened.
Mm-hmm.
So if it's hypermobile, it usually wants to be closed. And what generally helps to stabilize the SI joint is external rotation and adduction, or sometimes abduction, but basically external rotation primarily. And then what opens the sacroiliac joint is like internal rotation.
Mm-hmm.
So like just from a simple bridge, if somebody's got SI issues, I'll just take them up into a bridge, which sometimes just flexing the spine and coming up into a bridge will be destabilizing enough. Because if you really round back bridge, you kind of lose some of the low back support, or else you have lots of low back support. Maybe it's just the glutes. Anyway, some imbalance is happening between the low back and the glutes there usually. And you'll sometimes get pain there. But then if they can do a bridge, then I'll say version 1 is put a ball between their knees, something smallish, widen their feet and squeeze, and see if that provides relief or increases the discomfort. And then second versions, I put just a band around the thighs, one of those nice, TheraBand loops or one of those nice fabric loops, and put the feet together and widen the legs out in that bridge position. And that generally tends to kind of close that and stabilize that. And I say, which of those feels better? And that's a first step for me with pretty much every SI client, if they can tolerate those. Your guy probably was pre that.
You know what? No, this is interesting because that's exactly what I started him with.
Okay.
I put the band around his knees. Even before we tried even marching or anything, I just wanted to see where he was at. So I put a band around his knees and we did external rotation. I don't like having the feet all the way together. I have them slightly apart, just slightly.
Yeah, exactly.
Yeah. And I just worked it. And what was interesting is there was a definite range of motion on each side. It was a fairly light band. There was a difference on each side. The one that doesn't bother him had a much greater range of motion. The one that gives him issues was a little bit more limited, but he had range of motion. So we just watched. Okay. And then I had him maintain that during a bridge, just maintain the tension doing the bridge. Said it felt fine. I put the ball between his knees because I wanted to see if I can get a little bit of the pelvic floor firing, the adductors and whatnot. So I put a ball between his knees. He squeezed and he was doing his bridge that way. And again, we did more of a flat back bridge. I didn't have him roll up. And he said, this I could feel just a little bit on that side, just a little. He didn't say it hurts. He said, I can just feel a little bit there. I said, okay. So in my mind, it was, okay, is it worth doing? He definitely needs the adductors firing because that can help to center the pelvis So I was
Right.
thinking that was why I was using that. I wasn't doing it as an assessment as much as I was, okay, I want the pelvic floor to fire and I really want to get a little bit of internal rotation to get the pelvis to tighten up a little bit internally. Because sometimes by getting the adductors firing can help to pull together the pelvis a little bit. But it was interesting that he said that. He said, it doesn't hurt. It's just I'm aware of it on that side. I said, okay, but just awareness, not pain. But it's interesting that you say that. So that immediately I'm thinking in my head, okay, so he likes that side is definitely the hypermobile side because he likes it more closed position. That feels a lot better with the band. He said it felt fine.
Yeah. So that again, so sometimes I'll do that as kind of just to decide, like, am I going to go this way or this way? It's kind of my first little assessment for SI stuff, and it's
Yeah.
usually helpful. At least gives me a
Mm-hmm.
sense of they prefer to be more open or they prefer to be more closed. And again, I'm using those terms very lightly, so
Yeah.
don't take those as something other than kind of my metaphor for what's happening there.
Mm-hmm.
One of the things that I've played with trying to stabilize the pelvis with the adductors is taking that in external rotation. So like you're squeezing a ball
Feet
or you're
together.
squeezing, yeah. And oftentimes what I'll
Mm.
do is instead of putting it at the knees, so this is another little subtle point.
Yep.
Sometimes if you put something at the knees, the feeling that I have is when they squeeze the knees together
Yep.
against a ball or something, it pops the femur out.
Not
Not
literally, but
really,
it feels
but
that
it
way.
just
Yeah.
creates a little more space in the femur, which decreases the stability of the SI joint.
Yes.
Or
Yes.
can. Again, this is really subtle, guys, but you'll find that and you'll feel that sometimes the clients that are on the mobile side. So in that case, what I do is I use like a folded towel or whatever's appropriate
Mm-hmm.
size right up at the crotch, like at the
Yep.
top of the femurs, external rotation. So let's say they're doing feed-in straps on the reformer, or I'm not sure what the equivalent would be in personal training land.
Mm-hmm.
They've got both feet in, but they're externally rotated and they're holding and squeezing that ball or that towel up high up towards the pelvis.
Yep.
So they're really trying to bring the femurs as close as they comfortably can.
Mm-hmm.
And just a little fine point there. If you've got somebody who is very large in their legs, it's going to be a tiny, tiny towel. If you've got somebody, I'm thinking of one of my clients who's Asian, who when she stands, she's got a 2.5 or 3 inch gap between her thighs just because of different bone structure. She's going
Yeah.
to take a much bigger prop there, right? Because I don't want
Mm-hmm.
to pull the femurs out of alignment. I want to align them with that and then have them hold that with external rotation when they're
Yeah.
doing something like, leg lowers.
Mm-hmm.
So that's
Mm-hmm.
something I used to kind of really just find that stability that also, especially if I'm doing it on the trap table or the tower, allows that longer leg, if there is one, to actually be longer. And I can sometimes then also get the pelvis to be a little bit more balanced.
I like that. I like that. Well, what it taught me in working with him today is immediately after the session is I said, I got to put him on the reformer. I mean, that was
Mhm.
immediately my thought is, okay, bilateral, feet and straps, footwork, everything that's bilateral. I can do all of that and still work with spinal stability so I can still get his core engaged. Because I
Yes.
put him in, modified plank, off of a high table. And we did a couple of things there because he definitely needs core stability. But we
Yes.
can't do a lot of the traditional stuff because we need to keep him so bilateral. So it was very
Right.
much okay, we need to sneak up on this. And I told him that. I said, today's going to be investigative because we
Yeah.
don't know. When he said he can walk and feels comfortable walking and riding a bike, I thought, oh, well, if you feel comfortable doing that, then I'm thinking you must have more stability than I thought. And I watched him walk. He had good range of motion. He didn't have these little tiny baby steps. He had good gait. So I thought, okay, I didn't see any huge issues there or muscular imbalances with his gait. He walks better than most people his age do.
Hmm.
But when I started him doing other things, unilateral, just marching and things, even though a small range of motion, it was okay. So being more in a flexed position rather than extended position. And I thought about that. I thought, well, maybe he feels better in extension, hip
Uh-huh.
extension.
Right.
That helps to close the joint a little bit because it's getting the
Exactly.
glutes
Yeah.
involved and everything. So I said, okay, that's part of it. So I was trying to walk my brain through this at the time, just trying to figure out, okay, what's going to feel fine, what's going to feel good, and how can we still strengthen it and sneak up on it? Because I know in 6 months, I'm going to be able to have a whole nother batch of exercises because he's gained a lot of strength to get there. And I can
Mhm.
do more then. But right now I've got to sneak up on it because I've got to gain him strength everywhere around the area and do it without flaring him up.
So what's occurring to me as you're talking about that is also using props, padding, etc.,
Mm-hmm.
to stabilize his pelvis if he's supine. Because it sounds like he's
Mm-hmm.
fine upright. It's like he's better upright
He
than he
is.
is in supine. Like supine is tricky. And
Mm-hmm.
a couple things that happen in supine, if you think about it, anybody out there, if you have a hypermobile SI joint and you lie down on your back, even on a, well, particularly on a harder surface, that will put some pressure on the bottom of your sacrum, depending on how you're shaped, right?
Mm-hmm.
To kind of tuck it under, if you will, or counternutate it. Yeah, nutate it, counternutate it. There we go. To
Coordination.
kind of
Yep.
counternutate the sacrum, which changes the SI joint and everything else around it, right? And moves that
Mm-hmm.
sacrum in the SI joint just by being
Yep.
passively supine on the ground. Um, so it might be something where you'd want to work with a supported neutral for that, or give him something where he's staying and maintaining some extension, which can keep that sacrum from pushing onto the SI joint, if that makes sense.
Mm-hmm. No, that makes a lot of sense. It makes a lot of sense. And like I said, we didn't do a whole lot in the supine position, but that makes a lot of sense. That because yeah, once we got him in a standing position, he was fine. Everything else felt
Yeah,
fine. And again, this may be something as simple as, okay, I'm going to do a lot of indirect core work where we're not necessarily going to focus on a lot
right.
of spinal stability in the traditional sense, but I'm going to
Yeah.
hit him through upper and lower body exercises and just getting him more so that his body is moving through space a little bit more and having to balance itself against forces coming from all angles. So I think that that's kind of where my brain is heading for the future already.
Yeah, so thinking about a couple of different clients I've worked with, one of the things that I found really useful for them was basically things like suspension training or Coraline or the tower arm work on the reformers, right? Where basically like your arms are in something and you're leaning forward, so you're just basically leaning, and
Yep.
that is a really nice way to intrinsically fire the core. Again, you can use like you did a modified plank on the table or whatever, but I would also play with maybe doing that with the towel between the thighs if that's appropriate
Mhm.
for them, and in external rotation.
Yeah, that's an idea. That's a very good
Because
idea.
sometimes, and the other thing too that again, depending on your client, I also really look at what is their glute versus abdominal balance.
Mhm.
A whole lot of clients are really some are glute dominant and like they do everything with their butt. Basically every
Yep.
flexion action happens first from their butt, right? That's pretty normal. Version 2 is the butt never works and it all happens from the abdominals, both
Yeah.
of which have issues. But with the SI joint, I often really have to figure out, like, are they overusing the front, are they underusing the back, are they overusing the back, like where is that balance? Because that also will have a profound effect on the SI joint.
Yeah, and I don't know if you've noticed this, but I've gotten a number of people with SI joint as well as just low back clients who came to me from physical therapy. And some physical therapists are so glute, and they probably
Yeah.
needed it at the beginning, but they're so focused on getting the glutes firing that they do
Yeah,
become almost glute dominant in a lot
yeah,
of the exercises. And you watch
yep,
them move and you're thinking, ooh, maybe we need your quads to work here too. Maybe we need your
right,
hamstrings to work here too, not just your glutes. It's important,
exactly.
but we need that balance. And again, physical therapists have a very limited amount of time necessary to work with them, and they just need to get those muscles to fire. So I appreciate that they did, but sometimes it's our job to sort of, okay, let's balance that out and get everything else working around it.
Right, and a lot of times, yeah, exactly. I'm thinking again of a couple different clients. It's like sometimes it's like, okay, so you got the glutes now, they're working, but they're working at a 10. We need to turn them down to like a 5. It's
Yes.
not that they go away, because you need them in a bridge, you need them in walking, you need them in, you need them.
Hmm.
But maybe you don't need them like at 100, right?
Yeah.
And so a
That's a
lot of
good
times for
point.
me, it's that subtlety. It's like, okay, yeah, you're going to use them, but try not to have them be like the major power muscle in the body, which they can certainly be.
Yeah. And that's sometimes, I hate to say it, when they're told you have to work your glutes, you got to glutes. I do.
Right.
I had one client that would do exercises, and I kid you not, every type of lower body exercise with his hands on his butt. Is it
Yes,
on? Is it working? Is it on? Is it
exactly.
working? I'm thinking,
Yes.
you're doing the movement. It's obviously working, but I got to
Right.
feel it. I got to feel it. But he wasn't feeling it internally. He needed to use his common senses, his hands, to really feel that. And I kept thinking, oh my gosh, just allow your body to work. It's working, obviously. We've activated it. They're firing. Let it go. Let it work
Right.
naturally.
Exactly.
Let's let
Right.
the other muscles help out with this.
Use it in conjunction with its friends. Right.
Exactly. 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 So yeah, I've noticed that. And I have seen some people develop SI joint dysfunction who have had some of those gluteal issues, who it's just they're
Absolutely.
firing too much. I told you about
Exactly.
the guy who, I think I've told the story before. I was teaching in Seattle, and a guy who was in unbelievable shape. He had a body that, was an Adonis. And he came up with his girlfriend, and he said, I've had nothing but low back pain and sciatic pain down my leg for so long. And I just looked at him, and I said, stop squeezing your butt.
Mm-hmm.
He said, what do you mean? And even she whacked him, said, I told you. I said, you're standing here squeezing your butt. He said, I didn't even realize. And he relaxed it. And after about 3 or 4 seconds, he said, oh yeah, the numbness and tingling went away. I said, yeah, you're just squeezing it all the time. I said, look, I'm envious. You have a nice rear end. I'm envious. However, it's still going to be there, even if you're not squeezing it for dear life all the time. So
Yeah.
that can have that negative effect. And I'm sure all that was doing was closing off his SI joint all
Yeah.
the time.
All the time. And in his case, also probably clamping down on the piriformis and causing
Oh yeah.
piriformis syndrome, because that all can go together there.
Yeah.
Yeah. So that can certainly do it. And the other thing that could do it is thinking about, again, how do we spread the load over more of the chain? When
Mm-hmm.
the glutes are that overactive, I often find the erector spinae are not doing their job, like the whole spinal muscles are really not doing their job, and the hamstrings are not doing their job.
Mm-hmm.
And so that's where a lot of times it's like I'll really play with, okay, let's see what we can do to get, let's say, your erector spinae firing without your glutes.
Yep.
So I might have them like over a box where their legs are just like, your hips are flexed and their knees are maybe on the ground, and they're doing just like a thoracic extension, right?
Yep.
And they're going into their lumbar, but they're trying not to use their glutes to do it. Right? Would
Mm-hmm.
be the opposite of that, would be doing something like the lateral barrel back extension, where that whole posterior chain is really inactive or really
Right.
active. And then the other one is playing with hamstrings versus glutes in something like a bridge or any kind of hip extension exercise, and just say, okay, and this, I would have our hands on and say, okay, when is your glute firing? Like, put your
Mm-hmm.
hands there, and let's see if you can fire it, if they're overused, just a little bit later. Like, it'll come
Mm-hmm.
on, but rather than coming on the moment you're thinking about going backwards, have it come on a little bit later, a little more gradually, so the hamstrings have a chance to do their part of the job. That's
Yeah.
tricky. Retraining that whole posterior chain is tricky.
It really is. For me, the hamstrings, what I use is, I love to do the bridge, but I'll do it with their feet on a hard foam roller.
Uh-huh. Yep.
So they have that instability. And what I'll do is I'll just cue them. Think about bringing your heels a little closer to your butt as you're engaging, as you're initiating the movement. Just think about it. Don't move it. Don't move,
Right.
but think about it. Put it in your brain
Yep.
that that's what you're trying to do. And man, this is one you have to watch out for, because some people cramp up because their
Yes, the hamstring
hamstrings
cramp
are going to be
immediately
it.
can be.
It
Yeah.
is an incredible hamstring exercise, but those that can do it, it really wakes up the hamstrings, and then you can take them without it, and you get a lot more balance between the glutes and the hamstrings.
Yep.
Yeah,
Yep. Exactly. And then you just train that in everything, right?
exactly.
You train
Exactly.
that in your bridging, you train that in your footwork, you train that in feet and straps, you train that in any kind of hip extension work. You just work on that.
Yeah.
All right. So looking at the balance of either the spinae, the glutes, the hamstrings, how that whole posterior chain goes. And to take you back to your client, Brian, yes, you can start bilaterally, but at some point you will
Yeah.
need to do unilateral work, because if there's anything that I know about SI joint dysfunction when it's on one side is that changes how that entire side of the body works.
Hmm.
Like that glute may be less active, that external rotation may be less, it may be more active, right? Like that
Yep.
hamstring may be stronger, that quad may be weaker. Anything. I'm just, those are
No, it's
examples.
true.
There are many different things, but that leg will be like a different leg than the whole other side.
Absolutely. And if you think of life, we don't walk through life bilaterally. We don't move through life that way. When you do stairs,
No,
you're not going to,
no.
you don't jump up. We're not a bunny rabbit. We're not jumping step to step, you know, and that's the sort of thing that we have to remind ourselves is you do things more unilaterally than you think. Even just getting out of a chair. How many people are exactly, their feet are perfectly symmetrical and they're balanced between both legs? Nobody. If I swivel in this chair to get up, my legs are going to be slightly turned and I'm just going to stand up. Well, guess what? One's in front of the other. I'm going to put more weight on one than the other. And that's real life. That's just normal. So you're absolutely right. You have to eventually get into a little bit of unilateral stuff. And what I've done in the past is on either the reformer or our sled machine is lighten the resistance and have them in a little bit of flexion with the other knee, not extension, have them just basically almost matching the other foot so that they can almost stay bilateral within the pelvis to start with, and then begin to separate the two, but they're pushing mainly with one leg than the other.
Right.
And then begin to change and allow that movement to get a little gradual, a little bit larger, a little bit larger, a little bit larger. But again, we're talking about not so few degrees. We're talking millimeters when we're talking about that joint. This isn't the hip joint that has this huge range of motion. This is tiny.
Yeah. Yeah. So thinking about that, like, so when I'm trying to work getting somebody to unilateral from bilateral, because I think you mentioned that, but just to kind of reiterate that a little bit, one classic thing, which I think Brian talked about, but this is a little different way to do it, is let's say you're doing footwork on the reformer, is take the weight to whatever you think it should be. So decrease it from whatever they're used to, because you're going to do some single leg. And the first thing I just have them do is just focus on the weaker leg. You know, both legs are still working, but you're thinking about the weaker leg, the leg that you want to work on. I start with that, and then slowly, you know, as you said, lightening the other leg. So maybe if I'm on the ball of the feet, then I'm slowly shifting the weight a little more intensely into that leg that's less active, and I slowly work that, and then eventually we lift up that other leg. But just to get that going, and just know that for everybody, we've all got a dominant side. We've all got a less dominant side, period. And oftentimes that is, from my experience, hardwired from the moment we start to walk or crawl or something. And it doesn't really change for most people throughout their life.
Yeah.
So, you know, if one side is really the dominant side, it will stay that way unless you work the other side. We talked about this on unilateral work. But again, with an SI joint, I do want to get some strength in that leg. In the hamstrings, the quads, the abductors, the adductors, the calf. I want to get some strength in that leg because I'm hoping that strength in that leg will decrease stress transferring up into that SI joint. But getting that strength of the irritating the SI joint is often the trick on that.
And it comes back to balance. You want them to be as equal as possible, because I guarantee that that side is going to be weaker in certain regards. The thing that I wanted to ask you about and to get your opinion, because we're not supposed to really stretch them out unilaterally. And if I put them in any type of lunge position to get that hip flexor, it's going to immediately set them into an anterior tilt. So it's a lot more of a challenge off the edge of a table with their knees pulled into their chest is probably the safest way, and dropping one leg, I'm thinking it's about the safest way I think to do without flaring something up, because I can really control the pelvis and how locked it is. But even that, there's a little bit of, I'm still like, oh, I don't know.
So if I'm going to do that in that circumstance, two things. One, I could use the table, but I would put something under their low back. So I would give them something to really stabilize it. And maybe if it's something, depending on their shape, relatively substantial, not just a little
Yeah.
folded towel, but something kind of, so they can really almost stay in,
A half
I
roll or
wouldn't say an
something.
exaggerated, a half roll or something. Maybe, yeah, whatever's appropriate sidewise there, but just
Yeah,
something that
for
they can
them.
really stay in that slight extension, if that's the deal. The other
Flexion.
thing too is, when I have them do, like, let's say lunges on the reformer, right, which is a classic
Mhm.
place to do that, I will be literally on them to not move their pelvis out of neutral as they take that leg back.
Mhm.
Right, because as soon as you do, you lose the stretch on that anyway, right? So I'll
Yeah.
just like hold your pelvis here. Okay, take the leg back, stop it there, right?
Mm.
Stop. And I'll oftentimes have my foot on the shoulder rest, like stop there. And then I may say, okay, now just go to that and away from that. Find that range without moving your pelvis at all. And just go little bit,
Mhm.
little bit, little bit, little bit, little bit, little bit, and then release. And see if
Yeah.
I can get it that way. And I can't always. Sometimes it's just too many other things are tight and it doesn't really work. Um,
Yeah. I find sometimes you just need release work, you need some manual work, or you need to use a
yes.
ball on their
Exactly.
psoas or something just because
Yeah.
you're not gonna be able to get them into any position that doesn't cause them to shift that SI joint, however they
Precisely.
shift.
Precisely.
So, but I agree on the reformer. I was I was trying to figure a way to, because of the height of my reformer, I always found it, the difficulty for me was if I had like one knee on the carriage with a foot on the shoulder rest. Well, the other knee has to be bent because it's lower to the ground. Well, that immediately puts them into a shifted pelvis. So I kept thinking, how can I raise it up for their height through books or whatever, so that they could still remain neutral within their pelvis and allow that carriage to slide forward and back. And I'm still working on it. I'm still trying to figure out what works best in that position. Any thoughts on that?
Moon box, yoga blocks. You need something that's big enough for their foot to feel secure on and that isn't going to slide
Yeah.
on the floor. So a moon box isn't bad. It's a pretty good height. And the foam ones are light and easy. And I can just put a sticky
Mhm.
pad underneath them and even a sticky pad on top.
Yeah.
And that usually brings them up high enough to do that. Um, you can also do lunges with the knee off the carriage. It doesn't have to be on the carriage. I've done it both ways.
True.
On the carriage is a
True.
little bit easier. But I've also done it's a little bit funky. It's basically a single leg from Pilates line, single leg knee stretch, standing
Mhm.
up. So you're upright. You're not supported on the foot bar,
Right. That's what I was
right?
thinking. That's what I was thinking in my head. Yeah.
Yeah, and your foot is close to the shoulder. Your standing leg is close to the shoulder rest. Not it can be a little in front of it. The farther in front of it it is,
Oh,
the less stressful it is. And then
yeah, yeah,
basically you're
yeah.
standing up. I usually have like I'm either there supporting them or I have a gondola pole because it's a little wobbly when the first time they do that. Their foot is on the shoulder rest and they're pushing back and forth. It's a
Mhm.
pretty intense and useful hip extension exercise that can also
Mhm.
get some mobility going. And it's easier
Yeah.
to stabilize the pelvis in that position because they're upright
Yeah.
than it is when they're leaning forward with their hands on the foot bar.
That's a great idea. I've done it before in the upright position. Usually I use a gondola pole, and I will usually keep the knee on the carriage, just so I can keep their knees together and then bring one back slowly. And again, my hands are usually on their pelvis so I can
Yeah.
feel what's going on and only
Yeah.
let them go back. A lot of times it's an inch, inch and a half. I mean, it's not very far. Their
Exactly.
knee is not
No.
traveling hardly at
No.
all. So that and a lot of times I won't even put much resistance on. I'll put a very light spring, if at all. I just want the motion and for them to really feel that movement. And I find that the less resistance is on there, the more they have to really stabilize internally to make sure that they don't go out of control. But that's really challenging. Sometimes the heavier it is, the
Yeah.
easier it is for them to stabilize from the outside. But yeah, I'm going to try that with him possibly down the road.
The other place is the core line.
Yes, yes. I've
Just
thought about
standing
that.
beside the core line with your hands on the ladder or standing upright because that's
Uh-huh.
a nice stabilizer position, and then just the leg coming in and coming out.
Yeah, I've thought about that, or
Hip
even doing
flexion to
some
hip
puffing.
extension.
I was thinking
Mhm.
even something simple that's going to go into a little bit of hip extension that might
Yep.
that might work. And again, gradual for him. So yeah. And again, I think what you're going to realize in listening to this episode is a lot of it is going to be trial and error. It's a
It's all
lot about
trial and error.
Yeah, it's a lot about balancing because You could take 10 people with SI joint dysfunction, and they're all going to be a little bit different
Yeah.
because, again, this was a male. I had another male very similar, but he already had SI joint fusion, both sides.
Mhm.
So for him, we kept him bilateral for a long time, but we really didn't need to after a while because guess what? They weren't going to move. They were frozen.
Right.
He had his fused, and it was a success. I've had a number of people who have had it before, and the ones that are successes are fantastic. For them,
Nice.
they walk kind of fun, we can see them walking a little bit strange, but it seems to be working for them and they don't have that pain that they had before. So for them, they've all considered it a success in that regard.
Yeah,
But
that's good.
yeah,
I think I've worked with nobody or maybe one person who's had an SI joint fusion.
yeah, it's a little bit of a challenge at the beginning, but once I think like any other client, once you get used to the person, you realize where their limitations are and where their strengths are, and you start to try and work toward strengthening those limitations without exacerbating anything. And I think that's really the goal here is trying to figure out what can they do? What can they do safely? How can we strengthen the surrounding areas, balancing all the surrounding muscles so that they're working relatively equally, and really sneaking up on this, really getting them to be in that unilateral motion down the road. I told them we may get there 6 months. It may be a year. I don't know, but it's going to be a while.
Yeah,
It's
exactly.
it's going to be a while if we get there at all. Who knows? So
It
yeah,
has been for sure one of the most recalcitrant issues that I've dealt with. SI joint stuff. I've had clients
absolutely.
where we make progress, but it's slow, and
Yep.
it's like I work on the core, I work on the pelvic balance, I work on the leg balance, I work on the it's like you just kind of go. I work on the pelvic floor, like I just keep going back and forth. And the thing that's been helpful, I'm thinking of one client particularly, uh, is she's aware enough of where her pelvis is to kind of be
Mm-hmm.
able to cue it herself and know where is a better position than not. That's been
Nice.
really helpful because her feedback, like, oh, in this exercise, my pelvis does this and that doesn't feel good. It's like, okay, so let's not do that exercise, number one, but let's figure out, all right, you can feel that, you can hold that. Now keep that while we do X, Y, and Z.
Mm-hmm.
And that's not every client at all, as has been my experience either. She's been really helpful at teaching me more about how the SI joint moves, feeling the pelvis
Mm-hmm.
moving in different ways, and understanding some of that.
And I think patience is very important for this
Oh
because
yeah,
I hate to say this, these clients maybe for a long time and maybe forever be almost on a hair trigger with this area, that they'll be
yeah,
fine.
it's
They'll
really
have no
sensitive.
problems, but it's sensitive that they'll do something silly. They'll be in a
Yep,
car, they'll be in a different car, they'll rent a car and they'll be trying to get out and they'll twist funny. And they'll
yep.
immediately, again, it's like a hair trigger. It'll suddenly snap and go out. And it's like, oh, and then it takes a while for things to calm down and go back. If you
Mhm.
strengthen it, hopefully they get back quicker and they're able to
Exactly.
stabilize much sooner. But they also need to understand that there's no permanent solution in this situation. It may come back. And if it does, it's our job to strengthen them enough that they have, less time on the injured reserve, so to speak, that they're not suffering for as long and that they can snap back relatively quickly. That's our job. And that's really what we're here to hopefully do.
Yeah, and if there's anything you can do that like, is there relief situation? Like maybe it
Yeah.
is that bridging externally rotated or internally rotated, or if there's anything you can do that helps them to find putting that back in place, even if that's temporary, that's really useful. And I've also played with some different techniques to asymmetrical work to kind of get them
Yeah.
to find that balance again, and then they can hold that for a bit, and then they know how to re-find it once they've lost it or once something has disturbed that. Lifting something up or new stairs or buying a house with 3 sets of stairs or something like that.
I tell people we got to find the combination for their body, the combination to that lock.
Yes,
Because if
exactly.
for some clients, once we find it, they say, as long as I do that every day, these exercises, like 3 exercises,
Exactly.
or
It's magic.
I
It's
do,
kind of a little magic.
and they say, I'm fine. If I don't do it, if I forget for a few days, things start talking to me and I get right back on it and then I'm fine. So sometimes it is just trying to find that combination that works for them. And it's
Mhm.
like, good. you've got your exercises. They may change down the road, but for now, you know what works. So let's keep with that.
Yep. Yep. It's a maintenance scenario. Right. It's
Yeah.
not necessarily a fix-it scenario. Like some things we do are a fix-it, and that is often really a maintenance scenario that just, just commit, take care of yourself, and you'll be fine, maybe
I
over time.
I had a client once who said, if you could give me 3 exercises that I could do every single day and never have this problem again, I will do them every day for the rest of my life. And for some people, that's really what it is. And I explained to some people, these are yours. These seem to be working. As long as you
Yeah.
do them, you can keep yourself relatively out of this pain, out of this part of this discomfort. So guess what? Do it. Just make it part of your routine. Don't forget. And once they sort of ingrain that, then it's great. They're fine.
Yeah, exactly. All right. Well, there was a deep and wandering dive into sacroiliac
Yeah.
joint dysfunction. Lots of things there to think about.
Lots of things to think about, but I think there was a lot of things for people to try. And I think
Yeah.
really that's kind of what this is. And I think we've stated that a few times. It's investigative. You're going to have to figure out what works for these people. You're going to have to try this, try that, try something else. And when you find out what works, great. That's what it is. So we hopefully gave you some things that you can try. We gave you some, practical information, and, hopefully this will work for you, and hopefully, work for your client as well.
Exactly. Good luck with this, guys. Any questions, again, feel free to contact us. And I look forward to seeing you in the next one. Brian, you want to talk us out?
All right. So do us a favor, hit that like and subscribe button if you haven't already. The majority of the people who listen to this on a regular basis aren't subscribed. So please do us a favor, hit that like and subscribe. You can reach us at movingcombos@gmail.com or check us out on Instagram, Moving Combos. For Nora St. John, I'm Brian Ritchie. We'll see y'all next week.
Bye.